Welcome back. We continue now with our 50th annual convention and the 75th birthday celebration of the Actuarial Society of South Africa. If we're just meeting for the first time, my name is Encremilla Andrew. I and Roxanne are going to be your hosts for the rest of the day.
So it's been just over 3 years since the outbreak of the COVID-19 pandemic. And so allowing us time to reflect and analyze and review different perspectives to better understand things and hopefully learn lessons from past events in order to improve for the future. In these next two separate presentations that follow, we'll hear from presenters who will highlight the importance of actuaries in such a pandemic event, as well as share their processes and technical research and findings when analyzing the COVID-19 pandemic. A reminder that you are able to engage with the technical content and research findings of the presentations during the Q&A session at the end of each presentation. In this first session, we have Nick HUDSON here to deliver his presentation entitled Actuarial and Statistical Problems Around the COVID-19 Phenomenon.
Thank you very much. I'm going to start by claiming a first. My sister, who's much more interesting than I am, is on stage next door at the same time that I'm on stage here. She's not an actuary, she's a radio presenter, but there you have it. How often does that happen at a convention? Family affair, really. Most of us are old enough to remember how bad models were so implicated in the 2008 financial crisis. The dawn of the COVID phenomenon was greeted by a plethora of models predicting doom of strikingly similar scale, and without exception, utterly failing to bear even a vague resemblance with reality. Those models generally assumed that there was a deadly virus and that lockdowns would slow the spread of it, resulting in less dying. One would call the results comical if their impact on society had not been so tragic. When Sweden famously rejected the lockdown idea, the modelers who facilitated the locking down of the world projected that it would experience in a few short weeks a whole year's worth of extra death, translating into a weekly mortality rate some 6 times normal levels. That would leave them at the end of the year with twice the level of normal deaths. What actually emerged was that Sweden had a year of mortality in line with its 10-year average. Now, in our actuarial studies, we learn about a little thing called the actuarial control cycle, which amongst others entails testing our models against emergent evidence. In commercial settings, failing to employ the control cycle after a signal as loud as this one would likely result in the responsible actuary facing some very difficult questions, if not being fired. Now, the evidence that those models, called SIR models, or susceptible, infected, recovered models, were not merely incorrectly calibrated, but wholly inappropriate for application to the COVID phenomenon, and that the ensuing policy recommendations was wrong, was available abundantly and available decisively within weeks of the onset of the COVID hysteria. But it was all ignored. It was as if the actuarial control cycle had never been invented. At PANDA, the organization I co-founded along with a group of multidisciplinary professionals to push back against the catastrophic hysteria, we could see, for example, that completely different places with similar population characteristics experienced completely different mortality outcomes, and that these differences could not be explained by viral dynamics. Something else was at work. This observation led us to adopt an empirical modeling approach capable of subsuming all factors, not merely the theory of a novel deadly virus. And despite not being perfect, that model was very accurate. As the South African Coronavirus Modeling Consortium and the Actuarial Society continued to deploy SIR models, we outed their inaccuracy by making various predictions that were strongly validated by emergent evidence. For example, at the time of release of SACMA's revised model, we predicted that it would breach the lower bound of its comically broad confidence intervals in 10 weeks. We were out by 1 day. Similarly, we predicted that hospital bed demand would be just 5% of what they projected. And again, correctly, in the Western Cape, our model predicted peak utilization of hospital beds to the digit. In December of 2020, we engaged with the Premier of the Western Cape. We asked him what had made him spend hundreds of millions building 2 field hospitals. He said that was what the models told them they would need. We described the inaccuracy of the SACMA models to him, and he said he wasn't using them. He mistakenly, as it turns out, said that he was using the ASA model. He then astonished us by saying that he was investing in a 3rd facility. Now, as it turns out, it seems it was not ASA who was advising him, but a consulting firm using one of the varied but consistently wrong scenarios from the 2nd iteration of the ASA model. I hope that his claim about this will be investigated and that the failure of, by whatever consulting firm that was to comply with the normal actuarial control cycle will have some consequences, because the public interest was definitely not protected in that scenario. But building pointless facilities was the least of the travesties unleashed upon the public by woefully advised and highly pressurized governments. The financial and humanitarian consequences of lockdowns have been quite staggering. The established NGO Action Against Hunger finds as follows. Before COVID lockdowns, the number of people at risk of starvation was 135 million worldwide. By the end of 2021, that had increased by another 135 million people, and in 2022, it then increased by a further 67 million people. The result is that we currently experience about 10 million new deaths a year from starvation, 3 million of them among children. It's a staggering, staggering consequence of lockdown. On top of that, about $4 trillion of wealth has been siphoned off from the middle classes to the benefit of a coterie of billionaires, the number of whom swelled by a quarter over the lockdown period. Now, numbers take time to be updated, but charts like this one tell a story of the haves benefiting at the expense of the have-nots. And this is precisely the kind of outcome that PANDA had warned of in our first paper, which stirred up so much breast-beating rage and anxiety amid people swept up by the false narrative of the COVID phenomenon. If you're not convinced that such people were engaged in acts of immense folly, we have an interesting tidbit for you. Let's for a moment suspend judgment on that whole suite of SIR models. Let's assume for a minute that they were actually appropriate. And we ask the question, what happens when you deploy such models, reflecting one of the clearest and earliest available empirical results under the COVID phenomenon, namely that COVID exhibited intense age-graduated mortality, with deaths even among even vaguely healthy under 70s being negligible? What happens if you incorporate differential mobility for the at-risk elderly? Now, at this website, we have a model you can play with showing that reducing the mobility of the non-vulnerable by locking down causes herd immunity to be attained with higher prevalence among the vulnerable. Let that sink in for a minute. What it means is that in terms of the very logic of SIR models themselves, lockdowns can clearly be predicted to shift disease burden onto the people most likely to die, causing total deaths to increase. This is a stunning reality, and I invite you to look at this website and verify it for yourself. Okay, having argued that the application of SIR models is invalid, we need to get back to some reliable findings. We now have hundreds of studies validating this one from PANDA's paper in mid-2020. This will be familiar to a great number of you who have ever done numerical and technical work, which I imagine would be quite a few. Lockdown stringency was entirely uncorrelated with official mortality data. On the x-axis, we have lockdown stringency. On the y-axis, official COVID mortality. And that, ladies and gentlemen, is a paint splat. No correlation. Now, we can return to the point I mentioned earlier, that one of our first and earliest conclusions was that something else was going on other than viral spread, and that it had to do with where you were. Before exploring what that something is, let's explore the theoretical framework for this. A syndemic is the aggregation of two epidemics that exacerbate disease burden. Where two processes are present, statistical methods can be used to assess which is the more important and how much it contributes. And one of those methods is a type of Bayesian analysis. You look at which of these two factors elicits a differentiation in the objective population. And we get some very clear and for some people quite startling findings when we do that. When the presence of COVID or a PCR test, for example, is used as a flag, what we find is that the characteristics of COVID deaths are identical to the characteristics of non-COVID deaths among multiple dimensions. So age, gender, income, and comorbidity prevalence. And this strongly suggests, very strongly suggests, that COVID is not a causative agent. See what I mean by startling outcome? But if you flag people for where they were when they died, the proportion of death varies spectacularly by that flag. The virus would seem to obey political borders at a very granular level, which is, of course, impossible. Deaths attributed to COVID emerged to be very heavily determined by political boundaries at multiple levels of granularity. The combination of those two results, the failure of COVID to divide deaths into differential populations and the very strong tendency of geographic flags to divide them very strongly, suggests that variation in clinical and public health practices is a major culprit where excess mortality is involved. A second syndemic phenomenon was indeed operating in the background beyond the reach of media attention. Now, if this strikes you as something that's difficult to digest, I invite you to indulge in something of a thought experiment. Imagine that one day when no particular virus or bacterium or fungus was in circulation, you woke up to find that your local hospital administrator was announcing on television that certain changes would be made to his hospital's policies. Henceforth, patients with flu-like symptoms would be isolated. They would receive massively reduced attendance by healthcare workers. They would no longer receive antibiotics to suppress secondary infections. Crucial patient advocacy provided by the hospital visitation system would be terminated. The hospitals would administer a new drug called remdesivir, a drug of no demonstrated efficacy and associated with multiple organ failure. The patients would be put on ventilators, even when they had no kinetic difficulty breathing, partly to prevent the suspected aerosolization of viral particles that might endanger hospital staff, and even though the ventilator mortality rate was running at well above 90%. Now, I put it to you that if that announcement happened under normal circumstances, there would be an immediate public outcry. And everybody would be abundantly clear to everybody that such moves would result in countless deaths. And there is your syndemic, because that is exactly what transpired under COVID. Such practices were taken up more enthusiastically in certain hospitals than in others, and in certain districts than in others, explaining the stark geospatial differentials among COVID deaths. In terms of this hypothesis known as the healthcare fragility hypothesis, which has a rapidly increasing number of adherents due to the multiple data points supporting it, the COVID phenomenon is best viewed as a mass casualty event rather than as a viral pandemic. Right. So far, the contents of this presentation have been quite bland and uncontroversial. So before I turn to the hot button of the injections, I'd like to have an opportunity to loosen you up with some salient facts. The following statements are all true and presented in approximately temporal order. Number one, governments signed draconian contracts committing them to acquiring billions of injection doses prior to the dissemination of any evidence regarding their safety and efficacy. Number two, the results of randomized trials run by the manufacturers of those injections were released. These trials were underpowered, were not double-blinded, and groups vulnerable to severe COVID outcomes were underrepresented. Analysis of those trials demonstrated using the trial data that the intervention arm of the study exhibited worse all-cause experience under all relevant clinical outcomes. Worse all-cause experience under all relevant clinical outcomes than the placebo arm. The intervention arm suffered higher all-cause deaths, higher all-cause hospitalization rates, more serious adverse events, and higher all-cause severe morbidity. And many people are astonished to find out, even higher occurrence of COVID symptoms as defined by the study itself. Media claims of 95% efficacy for these products were premised on one non-clinical finding from the study, that of higher incidence of COVID symptoms in conjunction with a positive PCR test. It's a non-clinical finding. It's of no use to man or beast. Analysts found that the propensity to apply PCR tests to those with COVID symptoms in the placebo arm was multiples higher than the similar propensity for the intervention arm, suggesting profound crossing of the blind and invalidating that sole non-clinical result. It's astonishing. Number three, a legal case was brought by a whistleblower from a company called Ventavia, citing multiple serious irregularities at labs to whom administration of the Pfizer trial had been outsourced. Quite astonishingly, Pfizer's defense in that case was not that no fraud had been committed, but essentially that it had served up the fraud demanded of it by the US military. The Fifth Circuit judge did not accept this defense, but ruled that while those irregularities were problematic, they were not evidence of commercial fraud, because the contracts had been signed prior to commission of the scientific fraud. And that the fact that the FDA hadn't done its job in that it authorized rather than approved the vaccines left the matter out of the court's hands. Number four, and perhaps most significantly of all, Pfizer then performed a bait and switch. It distributed to the world a product fundamentally different from the one it had fraudulently tested in crucial regards. Number five, this list is long. Pfizer and the FDA went to court in an attempt to prevent the exchange of data between them from becoming public for 75 years. Now, it's important to note that Pfizer never responded to the allegations regarding the clinical findings of the trials, even though a central and early voice and primary author in the whole fracas was a respected and long-serving editor of the British Medical Journal itself. This is stunning, because the implication is that anyone who has ever recommended that anybody be vaccinated with the Pfizer product is wittingly or unwittingly arguing that even though the product is expected to make you more likely to become sick, to experience severe illness, to be hospitalized, or to die, you should take it so that we can have fewer positive PCRs. And that, quite clearly, is a ridiculous proposition. With these facts in mind, that was all preamble, I invite you to put aside your judgments, to forget about what the man on the TV may have told you, and to consider some data about these injections. Much of the evidence presented in favor of the injections outside of the fraudulent Pfizer phase 3 trials is classed as observational, as distinct from arising from a randomized control trial. Now, this is sketchy at best because of the very large difficulty in designing observational studies so as to eliminate confounding factors, and because of the extremely low fatality rate of COVID. The single most relied upon analysis regarding these injections is arguably that emanating from the UK's ONS, or Office for National Statistics. Based on aggregate data, it claimed that the vaccines had high efficacy, going even beyond the all-cause result arising from the Pfizer trial. After much foot-dragging, the underlying data was released. This took FOIA requests and constant harassment and badgering. And researchers immediately demonstrated significant problems visible in the underlying data. For example, if you look at this chart, this analysis of age-classified non-COVID mortality comes from that data. The gray line superimposes injection uptake on this rather strange non-COVID mortality line for the unvaccinated, which is depicted in orange. And once you've seen that, all credibility you may have attributed to that study should evaporate immediately, absent a coherent explanation for how the act of injecting a grandpa over here causes a grandpa over there to drop dead. You have to suspend all credibility to this analysis. There's clearly something going deeply wrong with the methodology of the study. This is just one of multiple problems from this study. And it's a distinct issue, for example, from the canard of categorizing people as unvaccinated for the first however many weeks after their vaccination. Now, no actuary should have any problem spotting the immediate problem with that canard, because, and it's very easy to demonstrate this will mathematically, artificially induce almost arbitrarily high efficacy signals, even if an observational study is unwittingly structured to compare one placebo with another. It doesn't require a live medication, just a placebo versus placebo study with that methodology will give obviously a false efficacy signal. This is what it looks like. Obviously, if there's exactly the same methodology for the two arms, no exclusion period in either of the arms, then the results are going to be the same, because we've got a placebo versus a placebo. But if you introduce just a 2-week exclusion period, you get an artificial efficacy for placebo versus placebo of 60%. And if you extend it to 3 weeks, that boosts the signal to around 80%. Remember, this is entirely artificial, a structured, manufactured example. And there were studies that have gone as far as 7 weeks of exclusion. It's fraud. It's scientific fraud. And of course, the other thing that happens here is after so many weeks, 10, 12 weeks, whatever, what happens? Trial's terminated before this effect can disappear. And yet this scam, because that's what it is an almost uniform feature of investigations into injection consequences. Pointing out that Groote Schuur Hospital was deploying it elicited what was perhaps the greatest and most coordinated media smear campaign that I've faced since I started speaking out against the madness. All of it, of course, based on complete fabrications. Now, as a rule of thumb, categorical studies relying on accurate placement and control for all material confounding variables are as scarce as hen's teeth. And you have to ask the question, what can we do about that? For our money, the most reliable form of investigation, plausible, is to conduct temporal correlation assessments for causality of all-cause mortality. It's not something we study in the actuarial syllabus. The Bradford-Hill criteria for assessing temporal causation are well known in public health. Lots of people know how to utilize them. They're well within the capacity of most actuaries to understand. And you can apply it to data like this. This is data from the Netherlands. And that data is crucially important because, and uniquely valuable, because that country conducted its vaccine rollout in a strictly age-based fashion. Each and every age group produces a chart like this. Now, I just want, sorry. I skipped a page, there we go. I just want to maybe just make sure you're reading the lines correctly. The blue is the summer and spring vaccination program, number of doses, and the gray on the right there, that hump, is the autumn vaccination process. Red is excess mortality for this age group. Okay, no challenge. Bradford Hill, tick, 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 all the way to the bank. The vaccinologist Dr. Theo Schetters, who did this work, infers from this work an accrued vaccine dose fatality rate of about 2,000 per million doses, making it even more fatal than the purported fatality rate of SARS-CoV-2. Okay, this is very serious stuff and very hard to look at without scratching your head. Other analyses are beginning to emerge. This one I have not had time to study with the degree of rigor I'd like. I know the author, he's a reliable guy. And he deploys a methodologically sophisticated approach to test for what's called temporal regime change and to assess data from neotropical countries where mortality exhibits very weak seasonality, so it doesn't produce a big noisy effect in your data. It estimates a crude vaccine dose fatality rate of 1,260 per million doses. So, yeah, a little bit low, but pretty much in line from a order of magnitude perspective with Theo Schetters' work. Notably, in this analysis, South Africa produces the worst estimate outcome, so perhaps we should be grateful that the vast majority of our population declined the opportunity to be vaccinated, despite the fact that attempts to coerce them were in clear violations of multiple codes of public health and human rights. An important note with regards to both these investigations is that the vaccine dose fatality rate exhibits a very strong age graduation. So it's a feature which ought to be explored for the same reasons I outlined earlier with respect to COVID mortality in the discussion on syndemicity. Now, it takes a while for research like this to come to light, not least of all because it's poorly funded and because we often have to undertake the costly step of deploying freedom of information requests to obtain data that should never have been out of the public domain in the first place. But there were early warning systems in place, and they had been for a couple of years sounding an unprecedented alarm. Look at this. This is the VAERS system in the US. It's a signaling system for adverse events, which the FDA is justly very proud of, not to mention legally obliged to maintain in good working order, and in respect of which it is a felony to input false records. And that VAERS system, Vaccine Adverse Event Reporting System, was sending out a signal orders of magnitude higher than any ever seen for any product ever before. And what the response was after this absolutely floored me, because I began hearing people spectacularly committed to lying, trying to make out that these vaccine records were input by anti-vax members of the general public. It's a claim which doesn't even stand up to very modest scrutiny. That's just an impossibility. Even worse is the claim that these injuries were really long COVID. Of course, it's obviously long COVID, a condition for which there is no sound clinical definition and which has failed to evidence its existence in any sound statistical test. They claim this even to explain the massively elevated rates of cancer and heart deaths being witnessed the world over. And the worst thing is that they know that we know that they're lying. When it comes to claims regarding the impact of the vaccines on COVID transmission, the warning signs came far earlier than this, by decades, in fact. Research into the question of whether serum antibodies are sufficient to elicit mucosal immune response necessary to prevent infection and transmission has been consistent and clear. There was no sign of such an effect. And when it came to the COVID injections, among the earliest findings admitted to even by the sainted Anthony Fauci himself was that there was no difference in viral titers between infected vaccinated and infected unvaccinated people. Yet, despite the non-existence of any plausible mechanism for transmission suppression, and in the face of abundant evidence that there actually wasn't any, the lie of transmission reduction poured forth from the mouths not just of Fauci, but of diverse characters such as Rachel Maddow and Albert Bourla, the CEO of Pfizer, and Bill Gates. Given that transmission reduction was the prime and virtually the sole motive behind vaccine mandates, this was, for me, a particularly disgusting turn of events. A somewhat depressing reality to acknowledge is the sheer lack of commerciality entailed in accepting the received narrative around the COVID phenomenon. By day, I run a successful private equity fund. Private equity management firms suffer one of the highest mortality rates in the world, principally because very few people are able to sustain the degree of skepticism that is necessary in an environment that's characterized by very intense information asymmetries. The lesson that every would-be private equity transactor has to learn in order to avoid obliteration is that claims made by people whose financial well-being entails making those claims are to be assigned very low credibility. Simple little principle. Sorry, wait a second. Yeah. The uncomfortable reality is that all of our media, our universities, our institutions of public health, and all relevant regulators are deeply in the pockets of pharmaceutical stakeholders, very deeply. This chart just shows the funding from the largest family foundation that happens to be also one of the largest investors in vaccines, funding just for South Africa. And I would just point out that there are some aggregations that need to be done there to work out the true scale of the funding at some of these institutions. They neatly pocket them into different divisions and mark them as if they're going to different places. But officers of these institutions, all of them, are able to speak out only if they are willing to see their careers destroyed. Therefore, anything they do say about the COVID narrative must logically be ignored. Dictums such as follow the science and appeals to authority of such creatures should ring hollow to anybody who hears them. In a similar vein, common sense dictates that under such conditions, it is wise to look at who is trying to censor whom. Throughout history, censorship has never been the objective of the good guys. I've been reminded so many times during this saga of Alexander Solzhenitsyn's great work, The Gulag Archipelago. His notions of the banality of evil and how the line between good and evil runs through every human heart have never rung truer for me than in the last few years. It is the rule, not the exception, that people who commit evil acts are generally sincerely convinced of their own good intentions. And an episode of evil that I would say surpasses any event in world history has befallen us these past few years. And it continues to befall us. Wait, what do I mean continues to befall us? As we speak, South Africa and many other nations are set to sign up to a World Health Organization accord and a subsidiary set of international health regulations that make the outrages of the COVID period pale into complete insignificance. In terms of these agreements, countries agree whenever a public health emergency has been declared to regard all the WHO's health recommendations as compulsory, including but not limited to mass mandated vaccination, mandated medical examinations, border closures, incarceration or quarantine of the unvaccinated, and mandatory censorship regimes. In short, whenever a health emergency is declared, the sovereignty of any nation and all civil liberties would be suspended for as long as the World Health Organization demands it to be. No condition is imposed on this other than the declaration of a threat, regardless of whether there is any demonstrated harm or mortality rate, and it can be imposed at the sole behest of the Director General, with no obligation upon him to follow any sort of democratic or consultative process. And I'll remind you that the person sitting in that chair right now is a former terrorist with a long history of human rights abuses. Now, agreeing to do this may well be contrary to our Constitution, and there's a legal fight to be had there. But what the Bretton Woods organizations did throughout COVID, and clearly signaled they were enthusiastic to do some more, is that non-compliance with World Health Organization diktats resulted in exclusion from the global financing system. And there are only a handful of nations on the whole planet who are sufficiently autarkic to survive that. The Accord also expands the scope of the very perverse One Health system. It's a creepy philosophy that extends the definition of health outcomes to include all sorts of non-human priorities. If you haven't heard of it before, I really suggest you read up on it. Both of these documents set up a requirement as well for a very intensive and continuous surveillance for viruses and their so-called variants. Now, they will definitely find some of these, as they exist in nature all the time, always around us. Okay? And next time, they will not have to fabricate a story about a pangolin and a bat in a bar. And this can then be used, the discovery of any kind of novel sequence, for the inception of further lockdowns of populations potentially all over the planet. And what waits in the wings is the thing called the CEPI 100-day Vax Initiative, which is then anticipated to deliver a new mRNA vaccine which will be proffered as the only path out of lockdown, under peril of financial isolation. To make matters worse, taxpayers will fund all of this nonsense, but the profits will go to the pharmaceutical industry. The surveillance setup and the bureaucracy behind it make it inevitable that we will have recurrent threats declared and acted upon. The funding involved here is nose-bleeding, far higher than for any endemic disease on the planet. The World Bank says about $31.5 billion a year. But that's a small fraction of the profits that stand to be made by the pharmaceutical industry in this process. And all of this is true despite the fact that no broadly circulating virus has produced even a minuscule fraction of the disease burden of major infectious and non-communicable diseases. It's all perfectly bananas, and unless you're entirely brainwashed, a recipe for disaster for everyone except the soon-to-be minted trillionaires who sit at the top of this epic food chain. It should worry you that not a word of this has been spoken in our parliament or any parliament anywhere in the world, and that the mainstream media have been completely mute on any of the significant aspects of this whole arrangement. You will appreciate why I am choosing to end by saying that I hope that this period during which we have accepted the refusal of people promoting the most damaging and extreme actions the world has ever encountered to submit their ideas to the scrutiny of their peers and to engage with their critics in public forums will come to an end very soon. Maybe our discussions together now can signal the beginning of the end of that blind acceptance. A sign of this would be one of the injection promoters accepting our long-standing invitation to submit their sanitized data and methodologies to us for review. It's a perfectly standard scientific process. And above all, as the fog of the COVID hysteria lifts, it's my hope that many more members of this profession will recover the common sense and the commerciality that should be their pride and joy, and see the evil for what it has been, that they will recover their courage and take a firm stand alongside me against the spectacular commitment to lying and say, no more of this abject nonsense. Thank you.
Thank you, Nick. Are there any questions from the floor?
There we go. If you don't have questions, we're going to play your video.
Kindly have a mic.
Mike?
There's a hand up here. Are the microphones going out? Over here? I don't see anybody with microphones. Why don't you just stand up and shout? I won't take it as rude. Oh, here it comes. No? Ah, here we go. Just while they're approaching you, something I'll mention. One of the FOIA papers that we obtained was the work of the behavioral science teams in the UK, the nudge units. If we run out of questions, I'm going to talk to you a little bit about that because it's fascinating. Carry on. Yeah.
Hi, Nick. Your VASE data, the presentation you showed, first of all, we have to acknowledge that there were a lot of vaccines that were administered during the pandemic. So have you adjusted your slide with the actual vaccines administered to people? Because obviously, if you look at the absolute number of adverse events, it would look large.
Yeah, surprisingly, it doesn't make much difference. I mean, I've heard this criticism. I actually made the criticism once before, but what I was shocked to find out is how many vaccines are administered in America. It makes no difference to the broad finding. So the incidence rate here is orders of magnitude higher. You just think through it. You have 26 vaccines administered to every child born in America, and a very high percentage of the population take flu vaccines every year. So there's billions of doses being handed out. It doesn't take away this finding.
I think it's actually helpful to show those stats because when you present a slide like that without the exposure, it is not helpful at all. Yeah. It is not objective. And when you say it like that, how are we supposed to know that there is a real difference?
Okay, listen, there are all sorts of things going on with that data. They're changing attention rates, changing age groups and everything. It's a signaling system, not an observational study. So it's not meant to infer a death rate. Only somewhere between 1% and 10% of vaccine injuries and deaths, respectively, end up on the system. They know that. That's been documented. So it's an early warning signal. And I'm not making a claim that this is something that you can infer a mortality rate from. No, nobody can make that claim. But the point is that that signal, which is designed to be reacted to immediately as you get something like that, was completely ignored. That's the problem here.
Nick, two just quick things. So you'd started off commenting on the Sweden mortality and the 10-year average. So I just went and did a quick check on a couple of sites, and the numbers don't seem to tie up with what I heard you say, so perhaps I got that wrong. If you could follow that up with a written confirmation, that would be great. And then the second thing was you had attributed the source to www.sars2seir.org, which is a website that doesn't exist. So again, if you could just provide some of the source material there, because I'm just worried that some of the comments you made about things being fantastical and all the rest of it might be well applied here too.
Yeah, that's no problem. I must have made a typo in the reference there. SARS to SEERS. Yeah, there should be an S on the end of that. Sorry. Yeah, what I will do for everybody's benefit who's interested, I'm going to assemble a list of all the sources in this presentation, and so you can go and click and read to your heart's content. I promise you I'm not making anything up. I didn't quite hear the rest of your question. I'm sorry, it's very boomy, the sound up here. Was there something that's unanswered there? No. Okay. Further questions? There we go.
Hi, it's Roseanne
Hello.
Harris. Mine is not so much a question as a comment. So I guess I feel quite sad, actually, listening to this in a platform here, and quite professionally disheartened. While some may have been locked away in their ivory towers, trawling through secondary data and evidence, trying to desperately support an ill-conceived initial stance, I've been fortunate enough to be working with dedicated teams who have approached this problem with integrity and rigor and scientific curiosity to unpack the evidence and contribute to saving lives and saving the economy. I work for Discovery Health, and we administer just under 6% of the population on the schemes that we are under our administration. And for us, COVID was real. Our team was dealing with real-world primary data. People who were sick, people who died, people who lost loved ones. There were 16,500 confirmed COVID deaths in our population, and we recorded a case fatality of 2.5%, just under 2.5%, and a hospital mortality rate of 15.5%. That's one death for every 6.5 admissions. Just under 82,000 of our members were admitted to hospital during COVID. And I assure you that there was not a conspiracy of doctors admitting those members. There is no evidence in our data to support any conclusion that vaccines did more harm than good. Quite the opposite, in fact. And transmission reduction was a valuable side effect of a program that was intended to protect people from severe illness and death. These are real numbers, and I can't help but feel the need to apologize to the many health professionals and everyone who worked tirelessly and selflessly during COVID, and to everyone who was affected themselves or their loved ones when we hear such hurtful misinformation. Thank you.
Needless to say, this is not the first time I've heard such a speech, prepared, never responding to any of the analysis performed. Just stop. Apply your minds to the data. That is what actuaries are meant to do. How do we explain that in multiple regions around the planet, 2020 ended with very high seropositivity and no excess mortality? How can you explain that if we have a deadly virus on the loose and not an epidemic of catastrophically deteriorating standards of care? It's very hard. Germany ends up with 10 or 20% upwards in some areas and 0 excess mortality at the end of 2020. 0. And there are entire swathes of the planet that had exactly this outcome. And I take incredible exception to the idea that somehow a volunteer organization of academics who are forced to work in private because the cancel culture, led by organizations such as Discovery, is so intense that they cannot do honest work in their own organizations. Those people are working for no pay and tirelessly and putting themselves at great risk. There is no question in my mind. And this is not about a conspiracy theory. What an immature approach to take towards a person who sits there presenting statistics. It's not a conspiracy theory. It's an alternate view. And we can engage. I'd love to engage on your data and methodologies, but you don't share it. Okay?
An alternative view. Thank you so much, Nick. A round of applause for our presenter. It looks like this is all the time we have. Thank you so much, Nick.